and welcome. We're so thrilled to see hundreds of you here today. Welcome to our webinar, 5 Ways Ultrasound Adds Value to Your MSK Practice. I'm Jeunesse Castonguay, VP at Clarius. A warm hello to all the physiotherapists, physiatrists, sports medicine specialists, orthopedic surgeons, emergency and primary care physicians, and so many others. Thank you for joining us as we share MSK ultrasound techniques proven to improve patient outcomes. We'll soon be taking you under the skin with live ultrasound demos to see how high definition imaging can might be diagnoses, so we can get to the heart of MSK problems. You'll learn how ultrasound can help you deliver more effective treatments, monitor progress, and motivate your patients like never before. But first, it's my pleasure to introduce you to your host. Dr. Ron Frankel is trained in emergency medicine in California. He's been using point-of-care ultrasound his entire career. He now practices in a busy academic teaching hospital in Vancouver as an emergency physician. Dr. Frankel is passionate about POCUS and education. We're thrilled he recently joined as chairman of our Clarius Medical Advisory Board. Over to you, Dr. Frankel.
Thanks, Jeunesse. It's a pleasure to be back. And we're taking off this webinar. On our last webinar, we interviewed pain management expert Dr. Rosenblum, and we talked about how managing patient pain really affects every single healthcare practitioner that's out there, no matter what walk of medical or healthcare practice we come from. And we cited a US CDC report that showed that 20% of Americans suffer from chronic pain. And we think that this statistic can be extrapolated worldwide, and it's substantiated by World Health Organization reports that also mirror that 20% number. And so I'm sure it's affecting every healthcare practitioner that's joining this webinar, no matter where they practice or what form of medicine or healthcare they practice. And while on last webinar, we focused on injection therapies, we know that multimodal approach to pain management is really the name of the game. And the multimodal approach should have a highlight piece of physical therapy that should be involved as helping our patients. But we all know that we face challenges with MSK management, particularly with diagnostics. You know, I liken to this image of a lot of our physical diagnostic, what we can do with patients is like looking under the hood of a car, but we're sort of restricted at the skin. So we know that everything's working inside, but we can't actually look inside at the motor, and we have to do our best guesses. And that kind of leaves us with a lot of challenges that I want to kind of highlight with a poll so that we really see that we're all in this together. If you can all participate and answer, which challenges have you experienced in dealing with MSK management? And we can see that we're all facing the same things. You know, the first is a broad differential diagnosis. There's so many options sometimes when people present with pain in a particular joint or body part. It's sometimes really hard to pinpoint the specific pathology or set of pathologies that's causing their pain. And then we have mistaken diagnoses. You know, we're all clinicians. We do our best to make our best guess, but oftentimes it's inaccurate. And then this leads to ineffective treatments. We have a misguided diagnosis, so we misdirect therapies, and it requires extra visits, or we experience and our patients experience a lack of improvement in their condition. And then they keep coming back and there's unclear progress. Sometimes we rely on subjective reports, but it's hard to get objective measurements of how is this patient doing over time longitudinally, and it's difficult to ascertain gradual progress. And ultimately, it results in complacent patients. You know, apparently we get a lack of results, we can't measure success, and patients are less motivated to participate in their long-term treatment plan, and so they're less motivated and have less drive to put in their work. So I'm kind of curious, I'm going to close this poll because ultimately the result of these challenges is suboptimal results with an increased risk to our patients. Let's see how we all kind of answered on those. Yeah, so we can see mistaken diagnosis takes the pot, but we're all in it with everything else that's aligned with it, right? Ineffective treatments, closely related to mistaken diagnosis, that broad differential problem, and unclear progress. It's a real challenge that all of us face. And that's why I'm so happy to have and invite Dr. Greg Fritz here today, who is really a master of his craft. Dr. Fritz is really a legend in his field. He has 34 years of specialty level physical therapy experience. He is leading innovation in imaging delivery in the hands of physical therapists. And as you'll soon find out, he is incredibly passionate about what he does. And there could be no one better to highlight the values that point of care ultrasound brings to MSK practices, no matter what your profession. So Greg, off to you here.
Thank you, Aaron. I want to maybe give the viewers a little bit more information as to who I am and maybe what gives me the right to sit into this seat talking about a subject that I'm most passionate about. My primary, you might say, day job is that I have 3 outpatient sports and orthopedic clinics that also specialize in industrial injury. And I want to give a little better picture of where I'm coming from clinically. On a daily basis, I'm still seeing patients as a physical therapist. And so as we talk about the MSK professional who's viewing this webinar, you need to understand that I might personally be biased in more of the diagnostics, more of the assessment of progress. And I am unfortunately not able to speak to the interventional as well as your last guest that you had. I'm going to move on now and give you kind of a picture of my journey into ultrasound. And it occurred about 25 years ago when I was sitting there in wonder that they could actually see my son moving around inside of my wife's uterus. And I was sitting there looking at this thing moving around, and all of a sudden it struck me, well, goodness, that's a femur. And I noticed that around the femur there was some structure. And I put on my physical therapist hat and I said, if through all that tissue, I'm able to see that material on my own son, why am I not looking at that on my own patients? So it took me about 10 years to talk my uncle, who was using ultrasound in his cardiac practice, to let me have one of his scanners, or at least let me have access to it. And then for years, or should at least intense months, my kids sat there with gel, and I with a Netter's book. They were watching Hogan's Heroes, and I was paying them their allowance by the hour to do that. And at the same time, I was reading all of the MSK stuff that was available online and in textbooks. And I took it to work finally when I had the nerve to say, I'm going to take a look at this stuff. And because I had access to PACS online, I was able to do correlating, and I could see what I saw and could look it up online. And then in the United States here, they opened up this certifying exam called the Registered and Musculoskeletal Phenologist exam for physicians. I sat for that, and I was one of 3 physical therapists that was able to complete that exam back in 2012. And since that time, like I told you, I have 3 clinics here in Washington State, and I have 4 doctors that work for me, and they're queued up as well to have this be of value to them in their practice. And so I get access through word of mouth marketing from patients I have seen, through the doctors that I've sent reports to, and through my own doctors working for me. And I'm telling you, even now, I have to struggle not to show you a text I got about 10 minutes ago from one of my own workers saying something about a condition that I just picked up 3 days ago. And it's that kind of stuff that's happening in real time. However, we've got meat to get into, and I want to be able to show this to to the viewers. And I'm going to do that in 3 cases. And those 3 cases, I hope that we can amplify the areas of value that I've found in my practice. The first case is involving Wendy. I was sitting in my house one Sunday morning and received a text from Wendy, who was, again, a personal friend. And in the text, she basically said, hey, I think I did something to my foot, because she was doing what she called jumping lunges. And those jumping lunges, during the course of one of the landings, she said something hit the back of her calf like somebody shot her with a rubber band. She said she wasn't having much more pain than just burning, but she was telling me how her foot was weak and she didn't have as much force in stepping off. And ironically, about a year before, I had done one of the webinars for the AIUM here on tendinopathy, and I had looked through YouTube, and I'm going to share with the viewers the exact exercise that Wendy was doing when she experienced what she experienced. So those of you out there who might have the volume down, which because I'm talking so loud, or intensely, you've got to hear this. I'm going to, hopefully this will play with the first hit.
I think, in our,
Go ahead.
In our current, COVID pandemic with, there's probably a lot of people doing home exercise, high intensity exercises like this. There's probably an uptick in patients presenting like Wendy.
Absolutely. And I find it ironic that the t-shirt says today is the day. Anyway, Wendy comes over to my house, mind you. I pull out the probe because I look at everything, and I take a look at her ankle, and clearly even the viewers have in their mind what they think occurred to both this young lady and to Wendy. But when she came over, she had no discoloration. She had very minimal swelling. It had been about 3 or 4 hours. She did have some weakness with push-off, but she could plantar flex her foot. I'm going to now take the actual diagram here as you get yourself prepped to go and do a demo for us. We're going to be taking a look, and you can see the linear probe at the very top and the orange call out under that anatomy. And we're going to see that the heel cord, or the Achilles tendon, is going to be run in long axis. So we would expect to see the fiber bundle of the Achilles tendon as it goes into the calcaneus, that's represented here by the number 2. We'll also see access, or have access to see the Kager's fat pad that shows up here as number 3. And we're going to be scanning both distal and proximal with the Clarius L15 high resolution probe in order to get a feel for exactly what this looks like in real life. And those of you who are watching, I'm going to ask that you take a look at the dimension and take a look at some of the structures, because I'd like to bring Wendy's case in directly following. I'm turning it over to you now, Aron. You
Great.
and
Well,
the model.
Yeah, walk me through this, Greg. So how do you do it? You start at the calcaneus here? Yeah.
Yes. I do want to see that the orientation of your probe is perfect. One end of it needs to be down on the heel, and the other one needs to be...
indicator to the head here.
Yeah, that's what we're looking for.
Right.
And now, obviously coming into view here, in the middle of the screen, we can see the fibers kind of take a 45-degree plunge into the calcaneus. And what I want you to see is that the fibers only attach to the right-hand half of this bright line. So the part where you see the fibers go dark in the image, it's where the fibers take an angle and go directly down into the periosteum. But what
that's what we're seeing right in the middle of the screen here.
Yeah, the darkness is where those fibers start to ricochet the sound away from the returning readers of the probe. But the important thing to realize is to the left of that, you're seeing this dark line. That dark line above the bright line is actually fluid from retrocalcaneal bursa. And as you slide front to back, you're actually able to see that dark little mass to the left. Yeah, you're doing a great job of bringing it on view here. That is the fluid that when he points his toe and brings his toe back, if Hunter can push his toe out, easy, nice and slow, push your toe out, good. And you'll see that that fluid will come out. And as he then brings that back, that part of the calcaneus will come again in compression to those fibers. That compression is going to be pivotal for you to see, because in just a moment, I will show you why that's incredibly relevant to the physical therapist working on patients that have heel cord pain. Go ahead.
Yeah, and then so in a normal patient, I mean, we're talking like there's 1 ml of fluid in there or less. That's such a small target to see. You have to like really see it in such high resolution to see that factor.
The fact that you can even see it on a normal patient is phenomenal, but it's kind of like the oil can. It's sitting there in front of the calcaneus, just ready to brush some more oil up onto those fibers. But now you're
walk me through the rest of this Achilles. Yeah, so here's this is the mid-span.
It's a good view as you can start to see the fibers come a little bit closer together, but that cloudy area below that is the Kager's fat pad. It's
this triangle.
And providing, and the darker colored material to your left, those are the flexor tendons. So you can see the fibers at the top. You can see that cloudy area, which is the Kager's fat pad. You can see the darker structure to the left, which is your flexor, your toe flexors and the digit flexors. And you can see the hyperechoic echo of the distal talus. So I want you guys
down at the bottom. That's that bright white line down at the bottom of the screen is the talus.
That's the distal talus. And I want the viewers to take a look at that long band at the top, going from right where it's wider to the left. You can actually almost count the fibers, the spatial resolution. And the spatial resolution you're looking in right now compared to any MRI, even the Max Teslas, is just phenomenal.
Yeah.
Anyway, good job with that, by the way.
That's a nice looking Achilles. Yeah.
It is. Yeah.
All right, great. Here, we'll go back to your slides.
And what I want to show the viewers is actually how things looked with Wendy. As soon as I have access back, if you can remember that last picture that you did, and if you can see my arrow here, you can see that dark area that I was telling you was the flexor tendons. That was that bundle right here. And what we didn't see represented in this particular diagram is Kager's cloudiness. In your model, we did. But I want you to keep in mind that the fibers up here are the fibers to the left on this video display. And I'm going to go ahead and hit play on this. And I want you to notice that when the toes go down into plantar flexion, the flexor tendons themselves are going to move.
Yeah, okay.
So the top, you can see the flexor tendons take the toe into plantar flexion, but what you can't see is that strand across the top of the screen, and you're seeing the actual stub of the distal component of the Achilles tendon right there.
And this is what I love about ultrasound, is the dynamic ability to evaluate, right? It's not just walking into the radiology suite and getting a film taken, but you just sit and watch while you're doing your exam, right? It's as if, like the mechanic, you're listening to the sound while you're turning the ignition, you're watching the thing spark, or like seeing where the sound's coming from, what's happening.
It's exactly right in front of you. And I remember when it would first shock me that that's just like Netter drew, or that's just like the anatomy book, which was crazy because anatomy was drawn. I do want to bring up the fact that there's so many complex differentials that to a physical therapist who's dealing with how do I manage these patients, it's not just important to confirm that what we thought was the case, but it also has nuances of treatment. I'm going to take it to the next slide here, because I want you to notice that the orange framed video here is exactly related to the diagram to the top left. And you're seeing that fluid bundle that we saw on your demo show up to the left, but you're also seeing at the insertion point of the Achilles tendon, there's a large bony knob. That's an exostosis. And you'll also see, if we go to the right, this is actual power Doppler, a component of imaging that brings the ability to identify whether or not the tissue itself is having blood flow to it. So I'm going to play again the cross-sectional axial view of the distal Achilles tendon.
Normally the Achilles has no blood flow, right? So if I had thrown Doppler on there, it would just, nothing would light up.
There shouldn't be, because fibers are fed not by passive nutrition, not by active energy, which you can certainly see represented here, that if this person were to go into dorsiflexion doing your classic Achilles tendon stretch, this would do nothing more than light it on fire even more. So I want to move on now. I don't want to spend, I've got so much material that I'm feeling like I'm wasting it on this, as opposed to the mid-span. And you can see that same view in the orange call out here, if you can see my pointer, that you were at your very last. This is a long axis view. We'll go to the short axis anyway. You can see the call out and the fibers on the far right. You can see the fluid and the effusion. And in this case, there was some partial tearing going on. But the point I'm trying to make is to be able to differentiate the mid-span lesion from the insertion lesion takes incredible value and places it into the hands of the physical therapist. I want to move on to the next. How does it affect
treatment though? I guess I'm wondering, I see patients in the emergency department, or GPs see patients with Achilles tears, is identifying where it's torn important for how we even manage them initially?
Yeah, it's incredibly important, because if you could imagine that a person's heel, the toe themselves, is going to go up into dorsiflexion. What we showed on your demo is that fluid that is located in the distal component of the heel cord is going to smash all of that calcification against the back of the calcaneus and intensify the compression and the friction. So as a physical therapist, we absolutely tell them it's time to start wearing wedge shoes at a higher heel to it, so we're not in any type of dorsiflexion. And stop your stair stretches, because we need to move on with other types of intervention where we can get nourishment and circulation to that. Now, that's oddly the opposite that I want to do with a mid-span tendon issue like that. I want to go into aggressive stretches in both as much as we can at a 45 degrees at full load, and even with excess weight. So it changes it pivotally. And to be able to know that, now again, there are people out there that say, well, I can touch it and it's going to hurt mid-span, or it's going to hurt at the insertion. Yes, but can you see calcifications? And can you see fluid coming in showing us that it's in the present inflammatory phase? I got to move on, or I'm going to run out of time here. Yeah. So I want to talk to you about EDWIN. And this is talking about a rotator cuff case that I know that that if a person talks to any MSK practitioner, this is really where we can differentiate what we see from what is available rapidly in my office, the ability to have access to this. This is a patient that came in to see me. He was a family physician himself and was moving into his new house. He was carrying his boxes in on his shoulder, and he apparently ran into the wall or the corner, and it jammed his head to the side, and he tried to protect the box, and he said he felt a snap in his shoulder. So clearly, as the pain began to get intense and he was losing control to be able to even lift his arm, he knew that what he had was a rotator cuff tear. And in his mind, he said, so in his mind, he said, I'm going to go see Fritz. I'm going to let him put his probe on this. We'll see how bad it's torn so he can talk to his surgeon friends and decide whether he wants to do that. I do want to pull up the diagram here, and I want to show what we're going to be doing in our live scan, our demo. What's pulled away on the diagram to your right is the actual deltoid muscle. So you're actually pulling that meat of the deltoid away. And we're going to start, Aran, having you place the probe in the position of the orange slice. That orange slice should allow us to see, if this video plays to the left, the two bony humps that make up the bicipital groove. And we're going to be looking for that hyperechoic, almost eyeball component of what is in that groove. So we're going to be taking it from there. We're going to then scan it up, and we're going to be bringing it over to be able to see the supraspinatus for us. So there's your model.
Let's check it out.
We're going to be able to take that probe. We're going to bring it down, and we're going to be looking again for
starting
those
here on the anterior on the anterior shoulder here, looking for that little notch, right?
Hey, buddy, you got it straight away. The only concern I have is that there is a darkness of the long head, and if you just wag that probe up and down, there you go. If you bring it down particularly, it's strange how far down you have to bring that probe in order to pull that in. But now you can see that sweet view of healthy fibers, fibers. Now let's go to the top. A little bit higher till the humerus just starts to go away, and then slide that whole thing lateral. So slide it lateral so that you can, and try to keep the long head, that hyperechoic brightness of the long head in view. So if you can go back to the long head just a little bit, slide back to that long head until you can pull it out. Yeah, right there.
All right.
And then rotate clockwise and come a little bit higher so we can keep the long head in view. Yep, that's great. A little bit now, perfect. And now, perfect. Slide lateral just a bit. And what we're seeing at the top of the screen is skin, of course. That dark cloudy area is his deltoid muscle. The next area that I would like to refer to as the tire on the wheel, that's your rotator cuff. Right. And so that little tire right there is your rotator cuff. And you're looking at between the infraspinatus and the supraspinatus, they kind of come together and interdigitate there. Let's go back with that view and see if we can't find the long head one more time, trying to keep that tire view in view. There you go. And so now we see the long head show up. And now as you come back, you can see the supraspinatus. Now, what I'd like to have you do is in the center of the supraspinatus, just spin your probe. We've got a good view of your probe, but just spin your probe 90, and bring it to an orthogonal view of that particular spot. There you go, buddy, because you're seeing the acromion right here. You're seeing the deltoid go over the acromion. You're seeing down below to the right the superior facet, and that's where the supraspinatus inserts. And this is the view. Go ahead.
No, I was going to say, this is impingement, right? This is where I do impingement testing.
This would be the view where you take his arm forward and out to the side just a little bit. Yep, and you're going to see the fibers slide underneath that beautifully.
And here it comes.
And let it come back out. Nicely done. You're seeing the fibers modify to come through that, and you realize then just how important it is to keep that free of grinding on that.
Yeah,
perfect.
Again, what a great dynamic test. You know, all the question about, like, there's so many reasons people would self-arrest and not do the motion, but to actually watch the tendon, hit, or the head of the humerus hit, or calcium get in the way and hit with the impingement.
I can't help myself interrupting you, because what I'm seeing on my screen is, if I had a pointer, I would be showing you the fluid that was being melted in the subacromial subdeltoid bursa. And what you're actually recognizing as you do that is how hard is it to bring that injectate down to an exact plane where you're seeing that fluid build up. And again,
you mentioned earlier also, I'm going to interrupt, but like
that's
talked
right.
about procedures. I know people do a subacromial bursa injections, and they're doing it blind. And I mean, you can see here, it's basically there's humerus, supraspinatus, and then deltoid, and the bursa is this potential space between the deltoid and the. So it's like an impossible space to get to without an ultrasound to guide my needle, right in from the lateral aspect. I don't see how you could actually hit that target blind.
There's envy within me as I see them come down, and when they do that injection, you can see that billow up and play out. Well, let's go back to Edwin, who felt that he had torn his rotator cuff, and I want to show you what an actual tear looks like. And if you can see my indicator here, up at the top is the deltoid, like we saw on your demo. But in this picture already, you can see this is your long head of the biceps, and where there should be a tire going across this wheel right here, that tire has blown a flat, only it's upside down. So I'm going to see whether or not, if I can hit play on this, we'll be able to get a picture of that come into view. I'm taking it now to the infraspinatus. This is the part of the supraspinatus that remains. And then you're seeing a little white line, which is the articular cartilage. And that articular cartilage is showing up because there's no fibers above it to stop the echo from being specific to that particular interface. So I'm going to now take it to the one to the right. This is, again, the view that we were saying before was the setup for doing the impingement test. And I'm going to see whether I can take it here. And I'm now just simply sweeping the probe. I'm not doing dynamic abduction. I'm simply sweeping the probe so that you can see where the supraspinatus should be attaching, which is on this slope here. And you're seeing right here that, again, that white line of articular cartilage show up as the retracted stub is right here. So we have a tear. It's a part tear of the supraspinatus tendon.
I gotta say, in my practice, your skills on the evaluation of the shoulder are so far beyond what I'm able to do. But that anterior shoulder, I do feel like it's within my wheelhouse to see a complete tear of at least the supraspinatus area of the rotator cuff. And I'm just looking for like you showed there, the 3 layers. And if I don't see one, something's wrong.
However, you did do the impingement, and you were able to see how that works. And this is actually, you're not going to mistake this one, because this was a massive rotator cuff tear I saw about 2 weeks ago. And this particular person, I said, I've got to store this for this upcoming webinar. Watch as this person attempts to abduct into the position or the posture where this should actually depress and go under the acromion, which is right here. Let me see if I can hit play one more time on that. I want to bring it back.
It just kind of looks painful to see the bones sort of hit each other,
And you can also see where the periosteum has had erosions for where the avulsive action was of the supraspinatus tendon. However, let's look at Edwin. This is Edwin's short axis view, and I'm going to hit play on this, and you can see here's Edwin's long head. Here is the long head of the biceps. Here is that tire we were talking about that goes over the top of the humerus. And the dimension of both the deltoid above and the supraspinatus dimension below assures me that Edwin did not have any particular type of tear on this particular view. In fact, what Edwin did have, and probably responsible for his discomfort, was that he did have fluid in the space between the deltoid and the top of the supraspinatus. And as you were pointing out, that was a potential space that, when there is irritation, becomes in essence a blister. And that blister, in response to that, will show up right here. And you can see it right there. That blister was because of friction. And that friction, in my opinion, that was because Edwin was dealing with a normal rotator cuff. But what he had is he had other issues that the numbness and the tingling brought my mind to as well, was coming from his neck, a cervical spine, which is
it's like a classic physician self-diagnosis, completely wrong. And, I
didn't mean to do that with it, but I did want to show that there are times when a person can refine that. We're going to move on now to my final case. And I know I need to hurry because I want to hear some questions on this stuff and we need to get moving, but this is my final case. Quinn broke my heart with how serious she was about her concerns. And it represents the difficulty that therapists and I'm sure doctors struggle with every day when someone comes in and says, I have to get back to what I was doing and I want to get back now because it's everything that I'm for. And in her case, running was her antidepressant. She had tried other things and she broke down in front of me saying, I've got to get back to running. But her symptoms, for those of you who are out there listening, you're going to nail probably with just the story of her symptoms. When she first stepped out of bed in the morning, she had severe pain for the first little bit, but after about 10 or 15 minutes, that pain dropped down to a modest level. That pain worsened to where she wasn't even able to stand on it very long by the end of the day. And her drive to run took her to the point of where she simply ran through the pain and hit a point where she couldn't do it any longer. So she went to her family doctor who tried PT, put her on non-steroidals and put her on an orthotic. She, of course, went back to running her 5 to 7 miles, and it just didn't get better. So she came to me and said, I have to have help. What can you do? What can you look at? So I'm going to see if I can't take this to the diagram. This is going to be a segue into having you take a look at the plantar fascia. So in this diagram, you're going to be able to see that the probe and its call out is going to be coming in the direction of the heel itself, but this time on the inferior aspect. And what I want to make very clear to the listeners or the viewers is that the importance of the fat pad. In the case of the heel and the heel fat pad, think of it like every time the foot falls, it's like a mattress that's under a falling body. And think of running and jogging is just a series of interrupted falls by the heel smashing down. So as you take the probe, I want you to orient it so that one part of the probe is in part on the bone that you can palpate on either side called the calcaneus. We're going to be looking for that hyperechoic bone of the calcaneus. The very top of the screen is skin, of course. That almost cloudy looking area above the bone is that fat pad that we were talking about. What we're looking at is a beautiful view of that fascial fiber coming from the right, all the way from where it attaches to the flexor tendons.
Maybe and a little more depth here. There we
go. Just
Just
a tad bit more so we can see some of that, the quadratus plantae muscle underneath that.
Oh.
So if you can now attempt to just gently take the probe and go toggling, where we go heel and toe, I want the viewers to watch the movement of that fat pad as it protects that tendon down below. Now I say tendon. Yes, that's perfect. It is long strand collagen. It's called fascia because it's really an aponeurosa or an aponeurosis. However, it's the dimension. And I also want to show you that if we take a look at the white dots to the right, the dimension here is, I'm going to guess, maybe 3 millimeters, because those white dots are, oh, perfect. Check it out. From that point there to the actual periosteal point, 3.4.
Did I measure right?
Know, close enough. Okay. Yeah. But what I want to have you point out to you is that the fat pad on a healthy plantar fascia should be twice the thickness, or somewhere between 0.5 and 1 centimeter. And as you, again, the way we measure that is if you remove some of your pressure from the probe, because we want to allow that fat pad to come back down. There you go. Now you're seeing the full dimension of what the fat pad is going to do. Now, if you just gently rock the probe forward to backward, you'll see that fat pad moving over the plantar fascia. Because the plantar fascia is so easy to see, you can immediately say, is it plantar fasciitis? And that's important, because the differential on that means it could be the spine, it could be the posterior tibial tendon, it could be the talar, the tunnel, the tarsal tunnel.
Other things you could look at with the ultrasound while you were there, potentially?
Absolutely. And in fact, if they're having heel pain and you can measure the plantar fascia, and that plantar fascia is well below the 0.4 or the 0.4 centimeters, you can go right to that. I wanted you to see what a large plantar fascia looks like, because on the model there you didn't see it. But if you can take a look here, this is a 1 centimeter thick plantar fascia. You can see that it comes all the way down from the point of the calcaneus here, all the way to here, and you can also see that fat pad itself has deteriorated some. I'm going to move on because I want to get to the meat of this particular case study. And I'm going to show you the scan and how it was with Quinn on my first session. This was Quinn's heel, top left. You're seeing the plantar fascia, and it was clearly enlarged. It was 7.38 or 7.4. And I want to draw out her passion and how she basically kind of told me how fast to get her better. And that was that she said, I've got to get back to running, but I will stop, I promise, if I can get back to running in 6 weeks. And this is where I'll tell you the beauty of POCUS is to me, because I took almost a fatherly attitude. I guess it would be more like brother. She's middle-aged and I want to think I am. And I came down and I sat alongside her and I said, listen, the only way we're going to get you back to running is if we take a look at this picture and first ask your feet what's wrong before we then go and interrogate what your heart wants to do. And so she did buy into the fact that if I can look at her feet and show her where the problem is, she's at least willing to consider that. I'm going to now take us a little bit further, I hope. I want you to see that the power Doppler is showing fluid flow between the fat pad and the plantar fascia. Now, when that happens, it tells me that really this is a function primarily of breaking down that fat pad, and the inflammation was occurring right in this area here. So I recognized, and I'm going to see if I can't keep going here a little bit faster. The next one is going to be up here. This is the short axis view, and you're going to see here that this is the dimension if we're cutting it, let's say, like a baguette. Instead of julienne fries, we're cutting it in an axial plane or short axis. Anyway, with this in mind, I was able to talk to her about where we want to go. And I'm going to take us to the second scan, which was about 4 months. That is, providing I can get us there. But clearly we knew that it was plantar fasciitis and that there was a fat pad degradation. There we go. But I want to show you that in 2 months, she was able to reduce the size of her plantar fascia down to about 6 millimeters. We were starting to see some fat dimension forming, and we actually had her at this time walking because she was able to tape her heel to pull some of that side fat down to underneath the point of her heel, and we were able to get her into some good shoes. And of course, I gave her the affirmation that she was doing great and that she was not abusing it, because I could see that there was no fluid in that area. And I also want you to see one important point. At 2 months, Quinn was still having disabling pain in the morning. Now, a patient that goes 2 months and still has that symptomatic pain, if I did not have access to the ability to assure her that she was on the right track, I wouldn't have been able to keep her as my teammate in getting her back to what she wanted to do.
Now, and you can't undersell, you mentioned it's 6 millimeters compared to 7 millimeters, which, doesn't sound like much, but as a percentage, that's a pretty significant percentage. And to be able to perceive that subjectively versus actually showing the change in the measurement, it's pretty profound, right?
It is very profound. She was feeling some improvement, but not nearly enough to nourish her hunger. But we were able to get her to walk, and she recognized that she had some ownership. Now, I did not scan her again for 8 months because she was actually in a satellite clinic, and she was doing 75% better at 4 months, and they were able to get her up to even moderate running at about 6 months. She was having no pain at the time, and my feedback to her was, I wonder just how that plantar fascia looked when I scanned her the 3rd time. And so clearly, as you can see, we're down now in this particular view, which was a short axis view, to about 5.5 millimeters. And it does make me realize that we don't have to have textbook perfect thickness in order for a person to be out of pain. So sometimes it edifies the clinician. Yes, I'd love to have her back to where the textbooks say it should be, but that's just not the way it is. However, I can tell you with all honesty, she would have never been compliant and staying focused on what I was having her do. And her joy that she had for accomplishing this task was just really rewarding to a clinician. And every one of these, I guess what I put these differentials in for was for people to realize that if I would have put the probe on the plantar fascia and I would not have seen a small fat pad, or if I would not have seen that narrow plantar fascia, these are other things that I have actually found that do make us think that. So in review, how is it that MSK has pivotally changed my patient outcomes, that I have truly seen a 25% increase in patient attendance? I can tell you statistically in the first year of me putting this into my practice. Now, granted, most of it was word of mouth from people I saw as patients. It's just now starting to get into the medical community. But that alone, 25%, and I get the joy I'm getting to use it. And to tick off just many of the reasons why I'm in love with this, it's real time. I don't have to order x-rays. I don't have to wait for that impairment mentality like Edwin had, that he tore his rotator cuff for how long, and he was, being cautious of that. The fact that I have confidence that confirms my diagnosis, the evidence, I can show patients that they're getting better. Now, we didn't even get into the fact that I can measure muscle thickness and can call them onto the carpet if they're not doing strengthening exercises. and I can show that it's been inflamed.
It's like the dentist, the joke is only the dentist can tell if you've been brushing your teeth, but now the physical therapist can know too if you've been doing your exercises.
If you've been overloading the tendon, because I can see that it's all, that's exactly right. But with us putting together the fact that I can aim this treatment to the right area, even let's example in the heel cord, I know I'm reducing visits. I haven't done those statistics, but I'm going to move on to the very last slide here, because
we want to make sure we have time for questions.
This is what comes up all the time is, yes, but is there money in it for me? Is there a return on investment? And I do want to address that just briefly and fast, but I'm going to leave this slide up for people to review that. And that's going to be, yes, there's reimbursement, at least in the United States. And for every evaluation that I do, I'm getting a net collection based on insurance between $45 and $160, and depending upon what zone you're looking at, that can add up.
And can I just add on? How did people? Is it all word of mouth? I imagine people are coming to you. You're getting more and more referrals because you have this extra expertise. Like where does that come from? How does that happen?
I've had 2 podiatry referrals in the last 2 days. I had a plastic surgeon referral on a trigger finger. And so what I think they're thinking is that this guy is actually seeing soft tissue, and we can get him in before the 6 weeks it takes to get an MRI. And so it's amazing when people say, well, if he could see that trigger finger snap through the hood for me, certainly he's got to be able to do it for you. And I wonder how much bullying some of these professionals are getting from patients going in saying, hey, well, Fritz can look at it. So I don't know if that answers your question. I don't,
People just know Fritz can look at it and the word gets around, I guess. That's why Edwin, the physician, went to you, right? I was thinking what would happen to him, self-diagnosed rotator cuff, probably self-refers to the orthopedic surgeon, surgeon says you need an MRI, 4 or 6 weeks later gets the MRI. Actually, your rotator cuff is fine. Well, everyone's scratching their head. It's 2 months later, right?
I will tell you, just to put the heart at ease of those that are feeling that they're going to be rocking the boat in their medical community, I was reached out to by my local orthopedic surgeon, who was a sports medicine physician, saying, hey, me and my 2 colleagues want to do evening labs with you to train on scanning. So I didn't even reach out to them. It is a neighborhood of people recognizing the value of this that come together and say, there's really not the silos that we think that there would be. Now I'm done talking. I'm going to pass this back to you, buddy.
Okay. Well, I'm just going to wrap up. I want to make sure we have time available for questions here. So let me kind of just get to the end here. To wrap up, we promise 5 ways MSK Ultrasound adds value to your practice. And I think, Greg, you kind of probably hammered on 12 or 15 of those. But, just to kind of really summarize the top ones that we sort of set it up was really, narrowing the differential, really figuring out what are the diagnoses at play, from the medical literature, study after study. Even just for joint effusions, we're terrible at diagnosing joint effusions. And that's probably the easiest low bar diagnostic thing you can do with a point of care ultrasound in MSK is see fluid in the joint. And even for something that low bar, physicians, particularly who have been well studied in this, are terrible at diagnosing even, knee effusions, ankle effusions. And these are professionals who that's like all they do are joints. So we know the ultrasound is just so much more superior for diagnostics. than our physical exam, that it's kind of a no-brainer at this point, I think. And then from the differential, we kind of go to the confident diagnosis, right? Being able to really see exactly under the hood what's going on, where the problem is, where the inflammation is. It really takes a lot of the guesswork out. And I always hear it takes the art of the diagnosis out, and perhaps it does to a degree, but I think I would take precision and confidence over art in modern medicine. But that's my personal, I think you've kind of gone that way too.
There's so many additional things. Yes, absolutely.
And then for the interventionalists, like for me and the ER or GPs or anyone who's doing needles, you have the probe, you see the problem, you can really either target intervention treatment or target the exercises and the rehabilitation strategy like you're doing to really aim for the proper treatment and making sure you're not doing the wrong one, like you alluded to for the Achilles, right? And then this is something that I don't really have privy to as an emergency physician, and I love hearing the story of motivating patients, longitudinal care. The patients I have longitudinal care with, it's usually not a success story. So seeing progress really evolve in MSK with someone really getting through, we've all had our journeys of injuries and knowing what it's like to rehabilitate. So to be able to really capture that progress and show it to patients, that's awesome. And I hope that the next time I need PT, my PT knows how to do ultrasound, but they probably won't.
They will soon. They will soon.
I hope so. If this is successful, we hope so. Yeah. And then, to be motivated, right? It's all about like, there's only so much you can do at every patient intervention and every patient encounter. They need to be their really own champion. So having a new tool to motivate patients, I think having that objective feedback and the dentist saying you didn't brush your teeth, that's pretty effective when you hear, I didn't brush, you didn't do your exercises, you're doing it too much. Having that kind of able to build a relationship, it's pretty amazing. So,
I am so grateful for what you've allowed me to share, and you can tell I just don't run out of words easy.
I know. And, this is like not one of our main benefits, but you alluded to, I think this is an evolving practice. And I think there are professional benefits for the practitioners beyond just the patient care, right? Like you alluded to, you distinguish yourself by having these extra skills. People come to you, they look to you as a leader, and, and there's ability to really distinguish your practice amongst your peers. And so that's really
no question about that, especially in physical therapy right now.
Yeah, and I love point of care ultrasound particularly because it's really a democratizing technology, and I think it really helps bring this diagnostic imaging into the patient bedside, no matter where the practitioner is, no matter what walk of care they're doing. So, physiotherapy, very non-traditional diagnostic imaging for physical therapists to have that tool in their hands, right? Podiatrists, plastic surgeon, orthopedic surgeons, naturopath, general practitioner,
athletic trainers,
athletic trainers, sports medicine, like the list goes on, and probably people we're not even naming because we can't even, conceive of it, but it's available with a little bit of training to anyone. So, with that, we want to make sure we have time for Q&A. I'm going to hand it back to Janez here and let her wrap up, and we'll save some time to collect. Please submit your Q&A below and we'll get to it in a second. If we don't, whatever we can't get to, we'll make sure to follow up with an email.
So thank you, Dr. Fritz and Dr. Frankel, for sharing your MSK ultrasound techniques and all the beautiful MSK imaging we saw. We will have a Q&A session, so please do ask your questions below. We've got a lot of questions already. I do want to take 1 minute before we go to the live Q&A to introduce Claris HD for the highest definition wireless ultrasound imaging. Claris HD linear devices that you saw in use today are specifically designed for clear, detailed MSK imaging to deliver several advantages. Claris is unrivaled for near field and high resolution imaging in a handheld ultrasound scanner. This best-in-class imaging of muscles, joints, ligaments, tendons, and cartilage, both at rest and in motion, has never been easier and more affordable. Claris shows you the fine details you need to quickly investigate an area of concern, as you saw today, and make a confident diagnosis. Each scanner is designed with 8 beamformers that deliver the image quality only found in traditional systems, but at a fraction of the cost of a cart-based system. Artificial intelligence is the secret that replaces complex knobs and buttons, making our scanners easy to use. Claris is also wireless, freeing up space with 0 footprint for portability in a variety of settings. You get free movement with no more wires getting in the way, also making it so much easier and faster to clean and disinfect, which is so critical today. Only Claris delivers linear wireless scanners with a free ecosystem that includes free apps for your iOS and Android devices with free updates, unlimited cloud storage to capture and manage your exams, and for unlimited users at no additional cost. Claris has no subscription fees. That means you can buy a single device for your practice and share it among physicians, each of you with your own devices and free Clarius Cloud account. And before we start the live Q&A, we'll just open up one last poll here. Again, we want these webinars to be educational in nature, but we also want to make sure that you have all the information that you need and want about our Clarius scanner. So I'm just going to pull up the poll here. So go ahead and select any of these options here that are available. If you'd like us to send you a quote and pricing information on our scanners, we'd be happy to do that. If you'd like to speak to one of our experts about the advantages of ultrasound and MSK imaging for your practice, if you'd like to book a one-on-one Clarius demo, I know that the image quality through massive Zoom webinars isn't always as clear, so you could do a one-on-one demo to really see it in action. And we are happy to discuss features. So if you've used ultrasound before and you'd like to understand the differences in our scanner and our features, we'd be happy to do that with you as well. We also have some on-demand MSK webinars that Dr. Fritz has done for us. 3 webinars that are very educational in nature with more case studies, and we'd be happy to share those with you here. I'm just going to give you 5 more seconds here to complete the poll. Again, please select any of these that you wish. 3, 2, 1. Oh, we've got more people voting. I'll give you 2 more seconds. 2, 1. All right. I'm going to end the poll. And what we will do now is go to our live Q&A. So, Oran, Dr. Frankel, and Dr. Fritz, if you could join us again. We've got a ton of questions here. A question for Greg Fritz. How did you become RMSK certified?
That's a very fair question. Can you hear me okay?
Yes, we can.
Yeah, I think twice a year, the American, I guess if, for us, it's the APCA, which is the, it's a physician certification group. They put on the RMSK certification in the US. It used to be under ARDMS, but now it's under something called Intellios, and it's the APCA, Accreditation for Physicians, APC, Certification, something. Association for Physician Certification and Accreditation. There we go.
Perfect. Thank you, Dr. Fritz.
Look into that. Sorry, I'm wasting time.
No, that's okay. That's okay. It's hard to remember all these acronyms at any given point.
A question to that, I wanted to add what someone brought up. Do you need RMSK to bill?
Yeah, that's a fair question. There is a billing limitation that does not include RMSK. And I'll tell you throughout, here's a good example. In the UK, and I'll make this fast, you basically have to say that it's within your scope of practice. So liability exists if you're doing something that you cannot create evidence for. You have the training to do that. So billing will occur. There are some insurances in the US that simply won't unless you're RMSK certified. That's a flat thing. But you can submit the bill if you do that scan, and there's criteria you have to meet. But as of yet, it's not an across-the-board thing. I hope that made sense.
My understanding for physician billing is for diagnostic ultrasound, it's there's not a clear accreditation process, and it's state by state, but in the States, in the US, but you do need to be able to archive your images as sort of part of the record. And so having a cloud system where you can just even on the probe hit a couple buttons or something in your app to record the images is really a kind of easy way to archive and satisfy that requirement for billing.
There are 2 big ones now that won't cover without RMSK. So in the States, at least, they've done that for a physician level as well. So again, it's just a way of keeping from paying.
We've got a question here, Dr. Fritz. Someone is wondering if you're using a Clarius machine, and if so, which one?
Every one of the images that I have shown was from a Clarius machine, and I regret that. I don't know whether it was my speed, but the answer is I use them all. The only one I don't use is your super high resolution one, and that's only because you guys haven't sent me one yet, and it's not because I wouldn't use it. I'm waiting to use it on the jaw because I think it's going to be pivotal information on the jaw with your highest 20 megahertz, but I have them all, and I have them in a little carrying case.
Great. Great. Okay. This one is for you, Dr. Frankel. Can I use the same probe you showed for other applications for any procedures or other diagnostics?
Yeah, I think the linear probe is a great question. So you can use the same linear probe for any high frequency application. So I do recommend, for if you're going to go into a broad MSK practice, having a high frequency linear probe is going to beat anything with lower frequency. Would you agree, Greg? I mean,
I would say,
you can use a curvilinear like the C3 model for deeper applications, but you'll never get that resolution like for the rotator cuff, and you really need that high frequency. But then you can flip and use the same probe for any procedure. So anything you can see diagnostically, you can put a needle in and watch your needle go in with excellent precision and accuracy. And then, for us in emergency, we can spread to soft tissue. So anything superficial in the top 3-4 centimeters gets really good visualization with a high frequency linear probe. So I'm looking at soft tissue infections, doing vascular studies. So whether you look at veins, arteries, or doing vascular access, if that's in your purview.
I would
nerve
say
blocks. Yeah.
I'm going to interrupt. 80% the 15, 10% the L7, and I use 10% curvilinear in a general sports orthopedic practice.
Perfect. There you go.
We've got a question here. Can ultrasound be used to help with diagnosis of carpal tunnel syndrome?
Let me tell you something. As of the last year, there is studies that show that it is even more specific than nerve conduction studies. And I know people are going to come out of the woodwork. Just send it to my email and I'll show you the well-juried research that shows ultrasound measurement it has the nuances of seeing whether the whether the nerve is actually compressed or whether or not you're just having conduction errors. So you can have a failure of conduction in the median nerve, but an ultrasound can show you that it's compression. So carpal tunnel syndrome, if it's from compression, you not only see, but you measure to make a difference. So I think it's not going to be long until it will be, brace for it, the gold standard. But I'm not a nerve conduction person.
You might have some nerve conduction specialists who don't want to lose their mortgage payments. Yeah, so
we're running just a little bit over time, but let's see if we can squeeze in one or two more questions.
Okay.
And I think this one is for you, Dr. Fritz, because they're not going to take my word for it. So how do you perceive resolution compared to a large clinical ultrasound machine?
That's fair. That's fair. I have a CART system myself, and I have an 18 megahertz CART system that I use. It's a hockey stick probe, and when I get down to fingers and I'm looking at some of the side slips, I can't beat it yet. But I don't have the 20 megahertz in my head yet.
We'll have to get you the new Claris L20 for that superficial imaging. Then you'll never need to use your cart-based system again.
If we're talking percentages, I'm 98% Clarius in my diagnostic practice, and it's 2% that I pull that thing out of my closet or all my other stuff. But I am almost universally Clarius, and I'm very confident in my diagnostics.
We've got just a ton of questions, and I absolutely apologize if we did not get to your question. We've hit the top of the hour and a little bit over. I just want to be respectful of every physician's time who's joined us today. At this point, I do want to let everyone know that we will have a recording of the webinar as well as a copy of the presentations available and emailed to you in the coming days. If we didn't get to your question, we will follow up with you by email in the coming week as well. And I'd like to just close off by absolutely thanking Dr. Frankel and Dr. Fritz for all of your insights, beautiful strategies and beautiful imaging today. Thank you very much. And as well, a big thank you for all of you who've joined us today. We definitely hope to see you at our next webinar. Thank you.
Thank you. We'll try and follow up with the questions, right? Are we going to get to the answers? We'll email answers.
We'll email answers. Absolutely. All right. Thank you, everyone.
Thanks for coming.
Thank you.